I'm an internal medicine doctor, and I've been with End of Life Washington for 6 years now, and I've met over 100 clients. So the first part of my talk, I'm going to talk about voluntary stopping eating and drinking, only with the medical aspects, because there are people following me that are going to talk about other aspects. And so I'm going to just tell you how you die from not eating and drinking. So first of all, I'm going to give you a list of symptoms that will probably make you feel kind of sick, because these are the most common physical and psychological symptoms that some terminally ill patients experience. Pain, fatigue, insomnia, loss of appetite, shortness of breath, nausea and vomiting, dry mouth, constipation, cough, swelling, itching, diarrhea, dizziness, incontinence, numbness, tingling, weakness. Kind of makes you feel like you want to die. The psychological ones are depression, anxiety, hopelessness, feeling like their life is meaningless, irritability, and if you're caregivers, you've all experienced the irritability of someone you're taking care of, impaired concentration, confusion, delirium, loss of focus, and loss of libido. So, most of us wouldn't want to stop eating and drinking. And for those of us that can't follow a diet for more than a few days, it would be the last thing we'd choose. But if you can put yourself in these people's shoes, and people who are terminally ill have often lost their appetite, so it's easier for them to do this. And the way they die is they become dehydrated. And once you become significantly dehydrated, your kidneys fail. And so they quit filtering your blood, and you don't get rid of all the toxic metabolic products that your body produces on a daily basis. One of the side effects of kidney failure is you can become delirious. So it's very important that if you ever decide to use VSED, or somebody that you know decides, that you have to have a very committed, supportive environment. You need a very committed and supportive physician or hospice if you qualify. Unfortunately, some people that choose VSED don't qualify for hospice because no one can predict that they have 6 months or less to live. Some people with chronic neurogenic degenerative diseases such as ALS, MS, multiple system atrophy, no one can quite predict that 6-month window. And sometimes people with COPD, congestive heart failure, are also unpredictable. So sometimes these people who are experiencing symptoms or situations that they find intolerable choose VSED. And one of the mechanisms for death with dehydration and kidney failure is that your potassium gets very high. And potassium is high potassium is a medical emergency because it causes a variety of arrhythmias of the heart or abnormal rhythms. Most people fall into a coma or fall asleep before those happen, so I don't think most of the people would experience those rhythms physically. I think the delirium and the confusion is a bigger issue with kidney failure. So basically it's a process of dehydration that works for VSED. I'm going to talk longer about death with dignity because there's so many other speakers that are going to talk about the various legal aspects, the psychological aspects of VSED after me. So death with dignity are for those clients, patients that have the 6-month window and decide for some reason that they don't want to put up with the symptoms they're experiencing. They don't want to put their loved ones through the emotional or psychological trauma of caring for them. They don't have the money, maybe, for their treatment. Sometimes they hate the fact that life is meaningless, that they're not having any fun, and they've lost their dignity. So these are some of the reasons for people that choose death with dignity. And it's legal in our state. You have to have 2 physicians that agree that you're within 6 months of dying. One of the physicians has to write the prescriptions. The other physician just has to agree that they know who you are. You have to be 18 years or older. you have to have a terminal diagnosis. You have to be in your right mind, so people with dementia or Alzheimer's disease do not qualify. And you need to be acting voluntarily. So the state's very careful to put in provisions so that no one's ushering their loved one away or to their death just because they are worth more dead than alive. So often, patients have a hard time finding physicians that will help them. A lot of physicians ethically don't feel like they can do that, or they don't want to do that. They may be employed by a Catholic employer that forbids them to help people in that respect or even talk about it. A lot of physicians don't know we have a Death with Dignity law. We're trying to raise the consciousness of more physicians. They may not want to be bothered. They think it takes too long, or they just don't really know about it. So End of Life Washington helps about 93% of the people that go through the process of Death with Dignity. And we think it's very important because it's a nonprofit. It doesn't cost them anything. The volunteers make house calls. They explain to the patient and to the family how the process works. They help them find physicians that will be either the prescribing physician or the consulting physician. The consulting physician job is pretty easy. It's a single-page form that says, yes, they know the patient. They're not terribly depressed. If they think they're depressed and using this as a form of suicide, they can ask for a psychological evaluation. They have to check the box that this patient's acting voluntarily, that they know what they're doing, let's see, I think that's all that's on that form. It's fairly easy. The attending physician meets with the patient. Both of these physicians have to meet with the patient, and the patient has to make a first request to one or the other of them, or to their own doctor or their subspecialist. Say it's an oncologist or a subspecialist, maybe a neurologist. You have to have a 15-day waiting period between your first request and your second request, and that 15 days starts the day after you make the first request. So if people wait too long, they end up not having the 2-week span. In the meantime, they need to meet with the second physician that agrees that they qualify, and then they have to, after they've met both physicians, they have to sign a piece of paper in front of 2 witnesses, and it's called the Written Request for Medicine to End My Life in a Peaceful and Dignified Manner. And of the 2 witnesses, one can be a family member, but one has to be a non-family member, and it can't be either of the physicians that are qualifying them. Once they've signed that, the prescriptions can be written 48 hours later, but they can't take them until they've hit the 15 days. So they could take the medicines on the day of their second request, but they can't take it any earlier than that. So with the patients that I've met, if I'm typically the prescribing, but sometimes the consulting physician, when they can't find anyone else, End of Life calls me and says, would you see this client? I typically write the prescriptions when I can, send it off to the pharmacy with a letter saying, this patient wants this option. They're not ready yet, because many patients I meet really aren't ready. They want it as an option. And I often start my conversation with them as, are you ready? I mean, are you in a hurry to take this? And some people are, because of pain or disability. Most people say, well, you know, I really don't want to take it very soon, but I really want the option. And we've heard over and over and over from families and clients that once they get this all in a row, they feel relieved. They just feel like, I have an option. Whether I use it or not, doesn't matter. And 30% of the time, people don't use it for a variety of reasons. Either they can't swallow, or they become demented, or they become incompetent mentally, or for whatever reason. We've even had occasions where the volunteers go to the home on the day they've decided they want to take the medicines, and would, all along the way, by law, the attending and consulting physician have to keep telling the patient, you don't have to do this. This is strictly voluntary. You can change your mind at any time. And even we've had people there with the medicine, and the patient said, no, I don't think I want to do it today. Fine, and we go away. So there are lots of steps there to make sure that this is what the patient wants. The medicines have to be, they're not an injection, and they have to drink it. It's a mixture of medications that cause the patient to fall asleep within about 5 to 10 minutes. They're in a coma within 15 to 20. And the time to death is variable. The average is about 2 hours, but it can go as long as 4 or 5. And so we always have to warn the family and the client that it's not a pill that they take. And it's not going to make them go away quickly, but they will die. We've never had anybody not die when we've given them various medications because they've changed over time. But and it's hard to predict who's going to die in an hour and who's going to take 4 hours. So I'd like to read you a thank you note from a family. And we hear this all the time, but I think this kind of tells you, it just gives you an idea of how thankful the families are. Dr. Law, you came to our house on a Saturday morning in April, pastries in hand, to write a prescription for life-ending medication for my husband, Scott. Throughout the 14 months since his brain tumor diagnosis, he had expressed to all of his doctors his desire to use the death with dignity law when the time came that his quality of life was gone. He felt abandoned when none of them would help him with this, and he was so grateful to you for coming to his rescue. He relaxed the minute the meds were in the house, his escape hatch, as he called it. As a family, we've decided to be open and public about how his life ended, legally and peacefully, so that maybe the next family won't face the same resistance. Thank you for being a light in our darkness. So I tend to get nervous and speak fast. So I suppose we have some questions. And Sally McLaughlin is the executive director for End of Life Washington. She's here today. So if I can't answer it, I'll refer to her.
All right. Okay, so we have time for questions. Yes, back there.
Hi, I'm an American citizen, but I'm living in Canada right now, working there as a nurse. And both the nurse practitioners and the pharmacists are part of the Medicaid assistance in that process. Do you ever foresee that for us in the States, nurse practitioners and pharmacists being able to prescribe and be at the bedside?
Oh, boy.
I think probably as the need increases, and nothing happens in America unless there's an economic impact. I mean, once there's an economic impact, that'll probably happen, but not before, is my guess.
So right here in the front.
Why is this not suicide? My perception is
Right.
the person is actively taking his life or her life,
Right,
and to me that's suicide.
right. It's semantics. We call it aid in dying, but euthanasia and active, we can't, that's a hard one for me to answer because that's what most people, you would probably never use this because of that idea,
Right.
okay? But the other people don't feel that way, okay?
I'll take it.
All right.
So that is a very big debate, whether it's suicide or not. First and foremost, in the law for death with dignity, it directly states it is not suicide. Obviously, the law doesn't tell us what words mean, but it says it's not suicide because it doesn't want to impact people's health and life insurance. So on the death certificate, what's written as the cause of death is the underlying disease. What we have discovered at End of Life Washington is people who use life-ending medication to hasten their death are not committing suicide. If they had the choice to live on, they would be living on. Suicide indicates you have some life to live and you're choosing to end it early. These folks are hastening their death. They're already dying, they're already terminal, and they're choosing not to go down that road, but to pick the time and the manner in which they die. So again, it is semantics. But it doesn't look, feel, act like suicide. I've never met one of these people who, if they had the choice, they wouldn't have lived on.
Thank you.
Another, yes, over here.
currently, what is the cost of the medications to the patient?
Cost of the medication to the patient is the question.
It's about $600 is the lowest. The highest is secobarbital, and it's anywhere from $3,600 to $5,000.
Why is it so expensive?
It's because the drug company that makes it knew that they could double the price and get away with it.
How much is it in Canada?
It's a Canadian company.
Yes.
So in that regard, is there any system in place to assist people who would not be able to afford the medication?
Some insurance companies will pay for it, not very many. Medicare does not, but we've had some patients submit the forms to their insurance companies and pay for it. But
Are there any other mechanisms,
Not so far.
nonprofits, or, no? That might be
there's the
something.
Costigan
There.
Foundation.
The who?
There's a foundation called the Costigan Foundation that we can apply to for help.
Yes, Hillary.
I was wondering where you would recommend, in your form in particular, the end-of-life Washington Advanced Directive to talk about VSED and death with dignity, because there's not really a specific area in the Advanced Directive to address those two things.
The question
Should they
is,
write it
where in the advanced directive would you address your choice for either death with dignity or VSED?
Yeah, sure. So an advanced directive for healthcare goes into effect when you are not able to speak for yourself. And if you are not able to speak for yourself, you can't use death with dignity. You have to be contemporarily competent. So those two, we are going back into our Alzheimer's directive, and we're going to put in a codicil about VSED based on the conference that we just were at. So I'm meeting with Dr. Lisa Brodoff next week, and we're going to be addressing VSED.
Great.
Yeah, oh, yes.
Until the Alzheimer's directive gets updated, the place where I recommend clients to make their wishes known as to VSED is just by adding a supplemental narrative statement at the back of the Alzheimer's directive or the back of the advanced directive. It can be handwritten, it can be typed, you just want it to have the same kind of formality as the directive itself in terms of being witnessed, and then it carries the same weight.
And the Alzheimer's, for those of you who are not familiar with the Alzheimer's directive, it will be addressed later in the day. So I don't want to spend a lot of time unpacking that question right this minute. So she said that if you want to address death with dignity or VSED, that you can add a narrative statement that should have similar formality to the rest of the advanced directive to your own advanced directive. So write an extra paragraph that specifies what you want and make sure that that's been witnessed. Yes.
Another question. I'm familiar with the organization Compassion and Choices. I'm not familiar with End of Life Washington.
That's because
You
they're the same
work-
thing.
Oh, okay.
We changed our
They
name,
changed their
Got
name.
it.
just to confuse everyone.
Okay, thank you.
Another question.
Are there any physicians here in Whatcom County that will perform that function?
Yes.
Yes, but I think the thing that's concerning to me is that it's not a very transparent process. And so one of the things that's important to do is to contact the Whatcom Medical Society. But I've been trying to work with people to make the process more transparent, and any ideas would be welcome.
I have a suggestion. When you see your physician, talk to them about death with dignity. Ask them if you found yourself in that position, would they help you?
What was the question?
They can't.
Yeah, they can't.
Oh, because
Their
he's,
Peace Health, they cannot.
Yeah.
If they're Peace Health, they cannot, but there are physicians in our community who do not work for Peace Health.
then if you call End of Life Washington, we can assign physicians to help you.
And
And
there, people have various levels of rule following.
So I'm just gonna say my grandma did go through and do death with dignity about 10.5 years ago in Oregon, and I was very young, and it was really heartbreaking for us to not be able to find a second doctor for quite some time, and so this is just
Okay, okay, Paul, this is.
Just a question to follow up on the suicide question. If people have it in their homes for weeks, months, because it feels good to have it there, is that permissible? You mentioned volunteers, or does the
We typically don't want the medications dispensed until the day they take them, because we don't want them to fall into the hands of children or people that are not
That's what I was
intended
worried
for.
about, but you said that they get comfort knowing that it's there,
They get comfort knowing that all they have to do is make a call
Oh, okay.
and they can get it the next day.
So it's not physically in their
No,
house?
no. Very rarely do we allow that.